Hi everyone, and welcome to our module on small bowel disease. We'll start by talking about acute mesenteric ischemia. So the mesentery is a membrane that attaches the abdominal wall to the intestines. This is a picture of what it looks like on the screen here. But when people say a patient has mesenteric ischemia, what they actually mean is that the patient has small intestinal ischemia. Mesenteric ischemia is the term used to describe ischemia of the small bowel. And so if you understand that, then it's easy to understand that acute mesenteric ischemia means the sudden onset of decreased blood flow to the small intestine. And the most common cause of this phenomena is ischemia involving the superior mesenteric artery. This is the blood vessel that supplies the entire small intestine except for a portion of the proximal duodenum. If we look at this drawing on the screen, this is the SMA right here. It gives off a bunch of branches that supply portions of the colon, like the middle colic and the right colic and the ileocolic. But then it also gives off all these ileal and jejunal branches, which supply most of the small intestine, except for a little bit of the proximal duodenum, which receives its blood supply from portions of the celiac trunk. The most common cause of acute mesenteric ischemia is an arterial embolism. This is responsible for about half of cases. And the classic condition that leads to an arterial embolism causing acute mesenteric ischemia is atrial fibrillation. When patients develop atrial fibrillation, they can develop a thrombus in the left atrial appendage, and a piece of that thrombus can break off and travel to the SMA, causing small bowel ischemia. You can also see an arterial embolism from a left ventricular thrombus or from thrombus that forms in the cardiac valves. And then some patients have extensive atherosclerosis in their proximal aorta, and a piece of plaque can break off, causing acute mesenteric ischemia. And when any of these things leads to mesenteric ischemia, often areas other than the intestines become ischemic as well. So you can see infarcts to the spleen or loss of blood flow to the legs, and that's because pieces of clot are breaking off. They're causing ischemia in the small bowel, but also in other parts of the body. Besides arterial embolism, other causes include a thrombosis that forms in the SMA itself. You can rarely have thrombosis in the veins that drain the small bowel. And then if the blood pressure becomes very low, for example in shock, you can have underperfusion of the intestines. This more often affects the colon and the large bowel, but it can also affect the small bowel, causing acute mesenteric ischemia. Acute mesenteric ischemia causes severe abdominal pain, but the pain will be out of proportion to exam. So, for example, the patient will say, I have excruciating belly pain, but when you press on the abdomen, you can't elicit any pain. That's pain out of proportion to exam. And because of these features of mesenteric ischemia, it's unfortunately often missed. People think that the patient is exaggerating their pain, when in fact they have small bowel ischemia. Besides the pain, ischemia of the small bowel often leads to blood in the stool, which you can detect on rectal exam. The diagnosis is made by CT angiography. First of all, this can image the small bowel and you can see necrosis. You can also see a finding called pneumatosis intestinalis, which is air in the bowel wall. This occurs when there's ischemia to the bowel. And lastly, angiography by CT scan can identify the area of thrombus or occlusion. Shown on the slide here is an example of an arterial occlusion by thrombus. This dark thing right here is a blood clot obstructing blood flow, so the dye goes down the artery, but it doesn't go any further because of the presence of thrombus, and you can see that on a CT angiogram in a patient with acute mesenteric ischemia. The treatment of mesenteric ischemia varies based on disease severity. Usually it's a surgical disease that requires an operation. In general, all patients are given heparin to prevent formation of further clot. Patients are usually given a proton pump inhibitor to limit acid going into the small intestine, and antibiotics are usually administered to decrease the chance that bacteria will gain entry into the bloodstream or the peritoneal cavity. Beyond these things, treatment options include resecting the ischemic portion of bowel, or in some cases a thrombectomy can be performed. This is an endovascular procedure, usually done by an interventional radiologist or a vascular surgeon, where you attempt to remove the blood clot and restore blood flow to the small bowel. Chronic mesenteric ischemia is different from acute mesenteric ischemia. In chronic mesenteric ischemia, there's atherosclerosis of mesenteric vessels like the celiac trunk, the SMA, or the IMA. This is similar to chronic stable angina of the heart, but it involves the small bowel. It usually occurs in patients who have vascular disease or risk factors for vascular disease, so things like diabetes or a history of coronary disease or peripheral arterial disease. If you look at this slide on the screen, which is an angiogram, it shows a stenosis here of one of the vessels supplying the small bowel. That's going to limit the blood flow to the bowel and cause hypoperfusion of the intestines. This usually leads to symptoms after eating, so patients complain of postprandial dull abdominal pain. That's because when you eat, You need more blood flow to the intestines, but the blood flow cannot rise because of the presence of a stenosis. And because of the postprandial abdominal pain, patients often eat less and they don't absorb nutrients as well, so weight loss is very common. This can also be diagnosed by CT angiography, although other forms of angiography can also be used. And the treatment is with revascularization. There are stent procedures, just like we use for the coronary vessels in the heart, that can be used to improve blood flow to the intestines. Moving on, let's talk about appendicitis, which is an acute inflammatory condition of the appendix, which is a blind-ended tube that hangs off the end of the cecum at the end of the small intestine. What happens in appendicitis is the opening of the appendix to the cecum becomes obstructed, and then bacteria and white cells and pus accumulate behind the obstruction, essentially causing an abscess inside the appendix. The cause of the obstruction to the opening of the appendix into the cecum can be due to a couple of things. It can happen due to a fecalith, which is a hard fecal mass. This is a more common reason for appendicitis in adults. It can also happen due to lymphoid hyperplasia, which is more common in children. When children have a GI illness, the lymph tissue in their small intestine can undergo hyperplasia, and it can grow to the point where it obstructs the opening of the appendix into the cecum. And when the appendix becomes inflamed and filled with bacteria and pus, it can burst and perforate, and this can potentially lead to peritonitis and sepsis. Let's talk briefly about the anatomy of the appendix. So the base of the appendix is always attached to the cecum, but the tip can migrate into many different positions, and these are shown in this picture on the screen. Shown in pink is a retrocecal appendix, and this is the most common location for the tip of the appendix. Other locations include subcecal, preileal, postileal, and pelvic, and the exam findings in the patient in terms of the location of the pain and the character of the pain can vary to some degree depending on the position of the tip of the appendix. The clinical features of appendicitis can include fever and nausea, but then the dominant clinical feature is usually abdominal pain. The abdominal pain of appendicitis begins in the mid-epigastric region in the center of the abdomen where I'm circling with my pen. And this happens because when the appendix becomes inflamed, the first peritoneal layer to become irritated is the visceral peritoneum, and this provides pain sensation that is sensed in the mid-epigastric region. Later, as the inflammation progresses, it will irritate the parietal peritoneum, and when this happens, the pain will move to the right lower quadrant. So the classic history of a patient with appendicitis is pain that began in the mid-abdomen but has now moved into the right lower quadrant. And within the right lower quadrant, the classic location for appendicitis pain is called McBurney's point. If you use your fingers to feel for the pelvic bone, you can identify the iliac crest, which is point 3 here. If you draw a line from the iliac crest to the umbilicus, 1/3 of the way along that line is McBurney's point, and that's the classic location for the pain of appendicitis once it has moved into the right lower quadrant. Some other clinical findings you can sometimes see in appendicitis are shown on this slide. Rovsing's sign refers to right lower quadrant pain when you palpate the left lower quadrant. Pressing on the left lower quadrant disturbs the contents of the pelvis and the abdomen, and if the appendix is inflamed, that will cause irritation on the right lower side. The iliopsoas sign refers to right lower quadrant pain with passive right hip extension, and this occurs anytime there is a retrocecal appendix. And as I said before, this is the most common location for the tip of the appendix. And then the obturator sign refers to right lower quadrant pain when you flex and internally rotate the right hip, and this is seen when you have a pelvic position of the appendix, which is what's shown in this image on the slide. The diagnosis of appendicitis can be made entirely by history and physical exam, although a CT scan or ultrasound can be used in some cases. When appendicitis occurs in children who have classic findings like pain at McBurney's point, these children can be taken directly to surgery. They don't require any imaging. And the reason is because in children there are few alternative diagnoses besides appendicitis that are likely, so there's no reason to use imaging to confirm the diagnosis. If the case is unclear, however, and you're not sure it's appendicitis, ultrasound is the preferred modality in children to diagnose appendicitis with an image. In contrast, when adults have classic findings of appendicitis, they are usually sent for a CT scan first before taking them to the operating room. And the idea here is that in adults there are many processes that can mimic appendicitis, things like diverticulitis or colon cancer or other disorders. So usually a CT scan is done first to make sure that appendicitis is what you're dealing with. This is a picture of a CT scan on the slide here from a patient with appendicitis. This is the inflamed appendix. These are not easy to identify on CT scan without some practice. Appendicitis can also sometimes occur in pregnant women, and when it does, ultrasound is the modality of choice for diagnosis because you don't want to expose the fetus to radiation from a CT scan. Besides the history and physical exam, you can find supportive evidence for appendicitis by measuring the white blood cell count. Most patients with appendicitis have a mild increase in the white count, and appendicitis is unlikely in a patient who has a completely normal white count. The management of appendicitis begins with preoperative prophylactic antibiotics. These prevent wound infections and also reduce the risk of the patient developing an abdominal abscess. This can be done with a single dose of a second-generation cephalosporin like cefoxitin or cefotetan, or you can use a first-generation cephalosporin plus metronidazole. Beyond antibiotics, the treatment is usually with appendectomy to surgically remove the inflamed appendix. This can be done as an open procedure or with a laparoscope, and this is a picture of a laparoscopic appendectomy on the screen here. The surgeon is using a tool to pull out the inflamed appendix. You should also be aware that there is some evidence that antibiotics alone can resolve some cases of appendicitis. Which patients should be treated with antibiotics alone versus which should go for surgery is still a matter of debate. As I said before, the feared outcome of appendicitis is perforation. When this happens, the patient can develop spikes in temperature, also worsening nausea and vomiting, and things like tachycardia. You can even sometimes see evidence of sepsis or septic shock. The pain when there's a perforation can be localized or diffuse. Sometimes the appendix ruptures and spills bacteria all over the abdomen. This will cause diffuse peritonitis type pain. But other times the perforation is contained locally in a phlegmon or abscess, and when this is the case, the pain can remain localized in the right lower quadrant, just like general appendicitis pain. When a patient has ruptured appendicitis, if they're clinically unstable, they should go for emergent appendectomy. But sometimes patients are stable with localized pain, and in this case, there are a couple of options. You can do an appendectomy, but in many cases, percutaneous drainage is done first. This involves inserting a drain through the skin to drain bacteria and pus from the appendix and the contained phlegmon or abscess. The reason this is done is because it's dangerous to perform an appendectomy when the appendix has ruptured. After you drain the appendix, you can then potentially do an appendectomy later, and it will be much safer once the abdomen has been drained of pus and bacteria. Moving on, let's talk about small bowel obstruction, which refers to obstruction of flow through the lumen of the bowel. And you should know that most bowel obstructions occur in the small intestine. About 80% of bowel obstructions are small bowel obstructions. Bowel obstructions of the large bowel, which I talk about in another video, are much less common. And small bowel obstructions can be complete, where there's no passage of any stool or gas, or sometimes they're incomplete, where the patient is unable to pass stool but is able to pass gas. When there's a complete small bowel obstruction, air that is swallowed cannot pass the obstructed region, and as a result, the small bowel proximal to the obstruction begins to dilate. This stretching and dilating of the bowel causes vessel damage. The bowel also sometimes can twist around intestinal attachments when it becomes dilated. And so eventually this can lead to bowel ischemia and intestinal necrosis, which are the feared outcomes in a patient who has a small bowel obstruction. The causes of small bowel obstructions can be remembered by the mnemonic ABC. A is for adhesions, which is the most common cause of a small bowel obstruction. Adhesions are fibrotic attachments that occur in patients who have had prior abdominal surgery. This is a picture of one on the screen here. So these adhesions can grow and develop around an area of the small bowel, and that can lead to obstruction. The B in ABCs is for bowel, referring to a hernia. So strangulated, non-reducible hernias, which are made up of small bowel, can become an area of obstruction. And then finally, the C is for cancer or Crohn's, which are also causes of small bowel obstruction. Crohn's disease can present as a small bowel obstruction from inflammation in the ileum or other parts of the small intestine. And then cancers of the small intestine or cancers from elsewhere that have spread to areas near the small intestine can also cause obstruction. So these causes, the ABCs, are the most common causes of a small bowel obstruction. There are other rare causes you should be aware of, especially because they come up on board exams. Intussusception and volvulus I talk about in other videos. Gallstone ileus is when a large gallstone obstructs the outlet of the small bowel. And then finally, there's a rare condition called SMA syndrome, which can cause a small bowel obstruction. The SMA syndrome is a rare cause of a small bowel obstruction. This syndrome can occur because the superior mesenteric artery courses over the distal third of the duodenum. If you look at this picture on the screen, which we saw earlier, here's the SMA, and it goes right over the top of the duodenum. So as a result, the duodenum sits between the superior mesenteric artery and the aorta, which is not shown, but which is out here. Now normally there is some mesenteric fat that keeps the superior mesenteric artery away from the duodenum, but if anything happens and the superior mesenteric artery is pressed downward, it will pinch the duodenum between the aorta and the SMA, and that will cause obstruction. So the classic board question of a patient with SMA syndrome is someone who has had recent massive weight loss. As a result, the fat pad beneath the SMA shrinks, and then you basically pinch the duodenum here between the superior mesenteric artery and the aorta, causing a bowel obstruction. The clinical features of small bowel obstruction include abdominal pain that's usually periumbilical, and then the classic feature of a bowel obstruction that makes it obvious on physical exam is distension of the abdomen. This is a picture of a distended abdomen on the screen here. This is what happens in small bowel obstruction. And because the bowel is filled with air, there will be hyperresonance or tympany to percussion. When you tap on the abdomen, it sounds like you're tapping on a hollow drum filled with air. When you listen for the bowel sounds, initially you can hear these high-pitched tinkling sounds when there's a bowel obstruction, but as the bowel becomes more and more distended, the bowel can stop to have any active bowel sounds and the bowel can become hypoactive. Patients will also complain of obstipation, which is an inability to pass stool, and they frequently have nausea and vomiting because contents cannot move through the bowels, and this can lead to signs of volume depletion on exam. And then lastly, patients with a small bowel obstruction will have biliary emesis. This refers to emesis that has a green color to it because it contains bile, and the reason that's the case is because bile from the liver cannot move through the obstructed intestines. The diagnosis is usually made by abdominal X-ray. The two classic findings are presence of air fluid levels and dilated small bowel loops. On the right, you can see these dilated small bowel loops. Note that they have these lines close together in the bowel loops. Those are the circular folds, and that tells you you're looking at dilated loops of small bowel. You can also see an air fluid level here. I've zoomed in. This is the fluid level found within the bowel. That's evidence of obstruction. As an alternative to abdominal X-ray, you can also order an abdominal CT. This can identify bowel obstruction and also precisely identify the area of the small bowel where the obstruction is occurring. Let's talk about the treatment of small bowel obstruction. First of all, if patients are unstable, they usually require immediate surgery. So patients who have evidence of peritonitis or unstable vital signs like tachycardia and hypotension, these patients are usually taken immediately to the operating room. Most patients with a bowel obstruction, however, will be stable, and it's very high yield to know that these patients generally do not require surgery and can be managed non-operatively. When patients have a small bowel obstruction, the first thing to do is to make the patient NPO, which means you ask the patient not to eat or drink anything by mouth, and then you need to place a nasogastric tube to decompress the abdomen. A nasogastric tube is a tube inserted through the nose into the stomach, and it can be placed on suction, and it will pull air out of the abdomen and decompress the abdomen so that you won't have the distension of the small bowel, which can potentially lead to complications. Beyond this, you want to give intravenous fluids because these patients can be volume depleted from nausea and vomiting. And then lastly, the management of small bowel obstruction usually involves administering gastrografin, which is a hypertonic water-soluble contrast agent. And let's talk about that now. Gastrografin is a contrast agent that patients can drink so that you can take images of the bowel, like this X-ray shown on the screen here, or a CT scan. But in addition to being a contrast agent, gastrografin is osmotically active, so it draws fluid into the lumen of the bowel, and this can be advantageous for a couple of reasons in patients with small bowel obstructions. First of all, it will decrease the amount of edema in the intestinal wall, and secondly, it will stimulate peristalsis. And because of these effects, gastrografin often avoids the need for surgery. Remember that many small bowel obstructions are caused by adhesions, which are fibrous tissue that constricts the lumen of the small bowel. By causing these effects on the small bowel, however, gastrografin can often get the bowel moving again and essentially work its way around the adhesive obstruction so that flow returns to the lumen of the bowel. So after you give gastrografin, you usually obtain an X-ray 24 hours later, and if you see contrast in the colon, like what's shown on the screen here, then you know that the gastrografin has made its way through the small bowel, and that predicts that the bowel obstruction will resolve without the need for surgery. I'll finish this video by talking about small intestinal cancer. Cancers of the small bowel are relatively rare. Most of the intestinal cancers occur in the colon, which I talk about in another video. But in terms of cancers that develop in the small intestine, the most common form is called a neuroendocrine tumor. Neuroendocrine cells are cells with both nerve and endocrine features, and they're found in many places in the body, including the small intestine and other areas of the GI tract, as well as the lungs and the pancreas. And when neuroendocrine tumors arise in the GI tract, the small intestine is the most common location. Besides neuroendocrine tumors, adenocarcinomas can rarely occur in the small intestine, although they are much more common in the colon. You can also develop lymphomas or gastrointestinal stromal tumors of the small intestine. These types of tumors also occur in the stomach, and I talk about them in the video on gastric cancer. Carcinoid tumors are well-differentiated neuroendocrine tumors, and they're called carcinoid because this word means cancer-like, and these tumors grow very slowly, therefore they're called cancer-like tumors. The claim to fame of these tumors is that they can secrete serotonin or other bioactive amines, which are hormones and other chemical structures that have bioactivity and have an amine group as part of the chemical structure. Carcinoid tumors are known to occur in the GI tract or in the lungs, and when they occur in the GI tract, the small intestine is the most common location. And because these tumors are slow growing, they don't often get very big or metastasize very widely, so for this reason they're often identified incidentally when imaging is done of either the GI tract or the lungs. A subset of patients with carcinoid tumors of the small intestine will go on to develop what's known as the Carcinoid Syndrome. This is a collection of clinical features that occurs due to systemic release of serotonin. This only occurs when carcinoid tumors metastasize to the liver. The reason for this is that the liver and the lung can metabolize or inactivate serotonin, so serotonin released from the small bowel will reach the liver but be inactivated, and it won't go on to cause symptoms of the carcinoid syndrome. But if metastasis to the liver has occurred, then those metastatic lesions can release serotonin, which can have systemic effects. And the classic symptoms of the carcinoid syndrome are episodic flushing and diarrhea. This occurs because serotonin stimulates flushing in the skin and also GI motility, leading to diarrhea. Other clinical features you can see in the carcinoid syndrome include telangiectasias. This is a picture of a telangiectasia of the skin shown on the slide here. These skin lesions occur in patients who have had long-standing carcinoid syndrome. They're caused by prolonged vasodilation of vessels beneath the skin. And places you commonly find these skin lesions are on the nose, the upper lip, or the cheeks. Carcinoid syndrome can also cause bronchospasms, so you can sometimes hear wheezing in these patients. And lastly, the carcinoid syndrome produces growth of fibroblasts and fibrogenesis. This usually causes problems in the cardiac valves. Patients with the carcinoid syndrome often develop fibrosis of the tricuspid and pulmonic valves. This can lead to either stenosis or regurgitation of these valves. Because serotonin is inactivated in the lungs, usually you do not see problems in the left-sided heart valves like the aortic valve and the mitral valve. If a patient has symptoms like flushing and diarrhea and you think that the patient may have the carcinoid syndrome, to make the diagnosis you need to measure the urinary level of 5-HIAA, which is 5-hydroxyindoleacetic acid. This is a metabolite of serotonin that appears in the urine in patients with the carcinoid syndrome. If you look at the bottom of the screen, serotonin is metabolized by monoamine oxidase into 5-HIAA. Unfortunately, the release of serotonin from these tumors goes up and down, so you can't simply measure the plasma level of serotonin or the plasma level of 5-HIAA. Instead, you need to collect a 24-hour urine sample and measure the total urinary excretion of 5-HIAA, and that will be elevated if the patient has the carcinoid syndrome. Once you've done this, you can perform a CT scan to localize the tumor and to identify metastases in the liver. Carcinoid syndrome is rare, but over the course of my career, I've treated 2 patients with this condition, and one thing I always remember is that the diarrhea and flushing can be miserable. The symptoms can be intractable and severe. Unfortunately, removing the tumor from the small bowel won't help because when the patient has carcinoid syndrome, usually that tumor has already metastasized to the liver. At that point, there are a couple of options. One is that you can resect the hepatic metastases, and this will take away the source of serotonin. Another treatment option is the drug octreotide. Octreotide is an analog of the human hormone somatostatin, and it's used to treat some forms of GI bleeding, and it's also used in other niche roles. One of those niche roles is the carcinoid syndrome. It turns out that many carcinoid tumor cells express somatostatin receptors, and so if you give octreotide, it will bind to the somatostatin receptors, and that inhibits the release of bioactive amines. This includes knocking down the release of substances like serotonin and also catecholamines and histamine. All of these can potentially be produced by carcinoid syndrome tumors. And so when you give the drug and it has these effects, the flushing and diarrhea can significantly improve. And that concludes our module on small bowel disease.